And boy, I really hope that microglia phagocytosis is the answer to sex differences in opioid addiction sensitivity, because that was exciting. But we don't know yet. So this talk is related to the review that Jill Becker and I wrote for this issue. And we're going to be focusing on not so much addiction in general, but opioids specifically. And so we all know that there are sex and gender differences in substance use disorder. And here's, I don't know if this ever worked. No, that's all right? Yeah, anyway. Okay, we all know that there are gender differences in substance use disorder, and this diagram, which is, as you can see from 2013, shows that the rate of increase for heroin use has increased at a far faster pace in women than men. Now, of course, men, the prevalence rates of opioid use disorder and heroin use are still much greater in men, but the rate of increase is greater in women. So a recent review came out from McLean Hospital, Dr. Kate McHugh, along with senior author Shelley Greenfield, and they were really focusing on sex and gender differences in human studies with a small nod to preclinical research. And I went ahead and tried making a word cloud of their paper to show that yes, women and differences come out on top, that there are gender differences, at least in substance use disorder. But the point of me showing this right now is to highlight that the majority of research in people, at least, has been on drugs like alcohol, cocaine, and a little bit on nicotine. I don't know if anyone spotted opioids. There they are. So really, there hasn't been that much research at both the clinical and preclinical level on opioid use disorder. I think that's changing, but we'll see. Now, the final point I'll make about this word cloud, which was fun to make, is that even though this paper was about more clinical studies, that little circle represents the amount of time spent talking about the brain. So there's a gap. There's a gap in knowledge. There's minimal published clinical or preclinical research on this topic, and I know that's changing, and we're probably going to hear a lot about it today and in the next session even. But going forward, I think that what I'm trying to get across is a typical scenario for how we go about studying sex and gender differences is to identify the gender differences in humans, in this case opioid use disorder, and they can be characterized into different types. There's bimodal distributions where either a male will have a trait or a female will have a trait. There's the more common average or mean differences where the trait might be the same, but males have more of it and females have less, or vice versa. There's frequency distributions, so there are different categories in which sex and gender differences can be under. And then, as preclinical scientists, we try to find or create an animal model that recapitulates a lot of the, or as many of the features of the model in humans. So this has been useful, but for issues like substance use disorder and many psychiatric illnesses, the human condition is very complex and is complicated by psychosocial factors, which rodents tend not to have. So what I'm going to do in this particular talk is to try to focus on the more molecular and the brain mechanisms of circuits and molecules that we know are important for substance use disorder, opioid use disorder, see if there are sex differences in those circuits and molecules, and then eventually the goal would be to translate that back or forwards to the human brain and the human condition. And some of the examples of these molecular and circuit mechanisms include gonadal effects, genetic effects, epigenetic effects. Okay, now this is a kind of a non sequitur, but one of the first things people often think about for sex or gender differences for drugs of abuse is, well, there must be pharmacokinetic differences. And there may very well be, but overall, and this is a study from our own lab showing that when oxycodone is given to rats IV, and then the distribution in plasma or brain is measured, there are no sex differences. And this has been shown for multiple drugs by multiple different labs. So it's not to say ignore it completely, but it's not a major factor in today's talk. So the questions outlined: are there sex differences in the neural mechanisms known to be important for different phases of opioid use disorder? And if there are sex differences, do they contribute to addictive-like behaviors in animal models of opioid use disorder? And finally, can we translate and leverage this knowledge to humans? So at this point, a lot of the research is really stuck at point one, but we're getting more and more into the other points. So I'm going to use this cartoon of the brain, which was in the review, as a way, as sort of a baseline to highlight the different systems I'll talk about. What's shown are dopamine, dynorphin, kappa receptor, mu opioid receptor, different neural systems that are known to be important for opioid use disorder, where they're found in the brain in areas that are important for addictive processes, and then also estrogen, androgen receptors co-localize with most of these regions, just highlighting that these are places that gonadal hormones can have actions. The first system that I'll talk about might be the most obvious, given that I'm discussing opioids, and that's the mu opioid receptor. So we know that mu opioid receptor agonists that have abuse potential, morphine for example, act in the brain at mu opioid receptors, which are GI-coupled, 7-transmembrane coupled GPCRs. And in general, they act to inhibit neural transmission. And again, in general, they tend to do this in two ways. Presynaptically, they can inhibit the influx of calcium, preventing neurotransmitter release. And postsynaptically, they can potentiate potassium channels, which decreases neuronal activity. So one example of sex difference that's been found in the mu opioid receptor is something involving the SNP, the A118G SNP found in the opioid receptor. Now this SNP is found in exon 1, and it causes a change in amino acids in the two alleles, so it has more of a functional consequence than SNPs that don't cause an amino acid change. And in a paper by McGew and from Julie Blendy's lab, what they showed that was really interesting is that the GG allele of this SNP in mice failed to show conditioned place preferences to morphine. Now, you might think that this was due to sex differences in mu opioid receptor expression, and they looked at that across the board, and even though the GG allele causes across the board decreases in mu opioid receptor expression, there was no sex differences. So that particular sex difference in conditioned place preference was not due to just lower opioid receptor expression. Now, a later study showed that GGP gamma S binding was different in the different alleles, and this had a sex difference. So what this study showed is that females, the lighter gray bars, were less able to activate their mu opioid receptor than males of the same allele type. So perhaps this is a reason why the females were less sensitive to the rewarding effects of morphine in the place conditioning study. Another study, and it's a group of studies, but another study from Enman et al. That just came out was looking at mu opioid receptor expression in the locus coeruleus. Now, this brain region is important for integrating opioids and stress. And its major output is norepinephrine, which goes throughout the brain. But what this group has shown is that despite or regardless of estrous cycle stage, females have less expression of mu opioid receptor in the locus coeruleus. an interesting twist on this that they showed is that if you treat males and females with morphine, the amount of cytoplasmic morphine receptor goes up in males, but doesn't really change in the females. An important caveat to this is, of course, in the white bars, you can see that the females at baseline have higher mu receptor expression in the cytoplasm. So what might this mean? It's not quite clear, but one idea is that the female locus coeruleus is less responsive to opioids, and hence that region, at least, might be less responsive to opioid dependence than males. Work from our lab supports this. No direct causal experiments have been done showing this connection, but what we're showing here is chronic escalating morphine treatment to rats, and then measurement of somatic morphine withdrawal signs, which the locus coeruleus is thought to play a role in. So simply put, the orange bars are the males, the green bars are the females, which could be the opposite as what Peg had for her color coding, but the point is that both males and females show somatic withdrawal signs after this morphine regimen, but that females show significantly less or fewer of these somatic withdrawal signs. Might this be due to the decrease in mu receptors in the locus coeruleus? We don't yet know. The next system that I'll talk about is dopamine. How can we not talk about dopamine? So the dopamine system that is of most importance to us originates in the VTA, the ventral tegmental area, and again projects throughout the brain, but primarily to limbic regions that include the nucleus accumbens, prefrontal cortex, and also to extended amygdala regions. So opioids increase dopamine in the nucleus accumbens. And this cartoon is supposed to demonstrate how that might happen. And this is old literature, and I know that there's a lot of nuances to this, but just for the purposes of this review talk, this is how we think of it. So morphine acts at the mu-opioid receptor, and if you focus on the right-hand orange cell, that's a GABAergic cell within the VTA. If you remember, the mu-opioid receptor is inhibitory, so activation of it inhibits GABA. So there you have less GABA, more dopamine, and that is responsible in part for reward. Oversimplified, but helpful. Now, way back when I graduated from high school, it was shown that acute morphine increases dopamine in the nucleus accumbens. In fact, it was shown that most drugs of abuse increase dopamine in the nucleus accumbens, and this is done by microdialysis. So this has led to the idea that the rewarding effects of opioids and most drugs are caused in part by increasing dopamine release in the nucleus accumbens. Now let's talk about sex differences in this. So seminal work by Jill Becker, again, early on, showed that amphetamine-induced dopamine release in the striatum is actually dependent on the estrus cycle stage of female rats. So animals that are in a high estrogen state in estrus show a greater amphetamine-induced dopamine release than animals that are in diestrus or a low estrogen state. Now, lo and behold, almost 25 years later, using more sophisticated techniques, this finding has been replicated. Go, Jill. So on the right-hand side, what you see is work from the Calipari and Nestler, and what she showed was that the firing rate of the dopamine neurons is not different between males and females in most estrus cycle stages, but that when females are in estrus, the firing rate of dopamine neurons is higher. She did some very cool and clever molecular mechanistic studies to show that increased dopamine during estrus actually leads to a phosphorylation of the dopamine transporter, making it more receptive or have a higher affinity to cocaine. So in the bottom graph, the bar graph, she showed that cocaine itself causes an increase in dopamine in estrus, but not in the other estrus cycle stages. So again, I think this highlights the point that there is a substantial literature in the psychostimulant field and other drugs of abuse, but less is known for opioids. Some recent unpublished work from our lab using microdialysis has shown that if you treat male or female rats with oxycodone at different doses, females show significantly more dopamine release in the accumbens than males. We have not isolated the females based on cycle stage, and it could be that the variability that you see in the females has to do with estrous cycle stage, but overall, females release or the extracellular dopamine is greater in females after oxycodone. So this fits with the literature on other drugs of abuse that I just showed. So what could it mean that females increase under certain conditions more dopamine than males in the context of opioid addiction sensitivity? And here it gets a little murky. So some very seminal work from Lynch and Carroll showed, using intravenous self-administration, that the rate of acquisition for heroin was faster in females. And this mapped on nicely to the idea of telescoping, which is a phenomenon that's often described in women with substance use disorder. After those rats were trained and had learned the procedure, there was no sex difference in these rats. Current work, or more recent work from our lab using oxycodone, so not heroin, didn't show any effect on rates of acquisition, and in fact showed that males took more oxycodone than females in those early acquisition days. And finally, an older study showed, using place conditioning, that morphine produced much greater conditioned place preferences in females than males. So you have some different behaviors, very different experimental paradigms and drugs, and you see different results. So I think it's important for us as researchers to have similar experimental paradigms, or at least to acknowledge the differences in these paradigms, because apparently they do make quite a different effect. So the answer's still out for dopamine and what the sex differences mean. So finally, I'll talk about the the kappa opioid receptor and its endogenous ligand dynorphin. Again, with this cartoon, we now understand how morphine increases dopamine. Dynorphin is also an endogenous opioid peptide. However, its receptors are found in a different place. They're found, at least in the case of the VTA dopamine neurons projecting to the accumbens, on the nerve terminals of the dopamine neurons. And what happens in the case of dynorphin is it can be released from the nucleus accumbens neurons, shown on the left, and causing a reduction in dopamine release into the nucleus accumbens and producing aversive-like states. Now, of interest, it's been shown for many years in humans and animals that chronic escalating opioid intake, chronic escalating drug exposure in general, increases the dynorphin kappa receptor system in the nucleus accumbens. So how might this be related to opioid addiction? So work from George Koob's lab showed that if you let rats self-administer heroin under a long access conditions, meaning they have lots of time to self-administer the drug, and by having lots of time to self-administer the drug, they tend to escalate their intake. And if you treat those rats with a kappa receptor antagonist, Norby, you don't prevent, but you reduce the escalation of intake. So that's what's shown on the left panel in the sort of the gray boxes. They also did a progressive ratio study using the same conditions, and they found that under the long access conditions, the Norby reduced the motivation to work for heroin. Now, this was all done in male rats, and the question still remains as to whether it's relevant for female rats. Just to reiterate the main point here, that as heroin intake increases, the dynorphin and kappa receptor activation are thought to increase, which drives negative reinforcement. And by blocking that negative reinforcement by a kappa receptor antagonist, you reduce intake. So we decided to take a step back and just look at, well, what are the effects of kappa receptor activation in males and females? Are they the same or are they different? And one approach that we took was to take sham and gonadectomized male and female rats and then ask if kappa receptor activation had this negative affective state response that's been shown in males so often. So to gonadectomize the rats, we performed the surgeries, and then 3 weeks later we looked at hormonal levels by ELISA, and you can see that they are reduced. That manipulation had no effect on its own on intracranial self-stimulation behavior, shown in the lower panels. But the key take-home message is that female rats, regardless of their hormonal status, showed a reduced sensitivity to the anhedonic effects of kappa receptor activation. So in this behavior, females do not respond as strongly to the negative affective effects of kappa receptor activation, and it does not matter whether or not they have circulating gonadal hormones. We thought that one reason for this might have to do with dynorphin, with the dopamine levels, and the reason we thought this was we discovered that there were much higher levels of tyrosine hydroxylase mRNA in the VTA of intact females compared to males. Pretty cool. To test whether this increase in TH expression in females had anything to do with the effects of kappa receptor activation on dopamine release, we collaborated with Mitch Reutemann at UIC in Chicago, and he uses fast-scan cyclic voltammetry. And basically what he showed is that, first of all, males and females under his conditions show no difference in stimulated dopamine release. So the top graph on the left, A, shows that as you increase the frequency of stimulation, you get similar amounts of dopamine release from males and females. But then what he showed is that if you administer U5O, which is a kappa agonist, it decreases dopamine in both males and females, but panel F probably is the clearest way to demonstrate that the amount of reduction that kappa receptor activation causes is significantly reduced in females, as if somehow females are protected from the dopamine suppressive effects of kappa activation. Now, I don't have much time, so I won't, sorry, Charlie. This work is from Charlie Chavian's lab in mice, showing a little bit different results in the sense that in this study, if you look on the right-hand panel, the females and males show similar conditioned place aversion to a kappa agonist. So there's lots of caveats that we can discuss about what that means. And they use their system of looking at kappa receptor signaling right at the membrane to show that there are sex differences in the analgesic effects, shown on the left, but not sex differences in the molecular, in the GERK3 beta-arrestin mechanism, shown on the right. So what might these sex differences in the dynorphin and kappa receptor signaling have to do with opioid addiction sensitivity? So here's an example where we don't really know yet, but it could be that dynorphin signaling in opioid withdrawal-induced anhedonia, which is picked up by ICSS, might be dopamine dependent and play a smaller role in females compared to males. Sorry, I didn't read the second one. The second idea is that the dynorphin system in negative conditioned associations, which is a very different behavioral construct than ICSS, might not be dopamine dependent, and it might play similar roles in males and females. So finally, I'll end with, again, this word cloud, more to show that a concluding sentiment of this review paper is that the gender gap in the prevalence of substance use disorders has been shrinking. And the conclusion is that this might be attributable to social and cultural factors and not biological sex differences. So what does that mean? Is that a depressing end to this seminar? No. So we think that, based on that review and other evidence, that the prevalence might be similar between males and females. That's fine. But that the underlying molecular mechanisms are different in some cases. And these have to do with the systems that I told you about today, and they have to do with others that are described in the review, and they include additional genetic, epigenetic, and hormonal effects. So the idea would be to focus on the molecular and circuit mechanisms and determine if there are sex differences, and then determine if those occur also in the human brain. So finally, I'd like to thank my lab and of course, Jill Becker, the co-author of this review article, and funding from NIDA and other collaborators. Thank you very much.
Thank you, Elena, for that great talk and a great transition into the next special session that is going to discuss the opioid crisis. We have time for maybe 1 or 2 quick questions before we need to switch over the podium. I'm also going to invite anybody, because Neil didn't have a chance to answer any questions, or anybody else from the panel, if you have any other introspective or prospective sorts of ideas on the field. Elena, can you comment while people are sort of transitioning here? You sort of ended with a summary of that maybe there's not as many dramatic biological differences, sex differences anyway, in opioid use disorder. It seems like most of the biological evidence really was stemmed from animal studies. Do we have any biological evidence or any outcomes that have been examined in humans, and especially as it relates to a lot of Jill's work on escalation of addiction?
I mean, I would say very simply and broadly no, but I think it's one of these examples of where you have 10 papers that say one thing, 5 that say another, and 2 that say no change. So that's the state of the literature in humans right now.
A lot of work to be done,
yeah.
Certainly.
Time?
Question?
Yes. Well, actually, I just have a comment. I wanted to make the point that the gonadal hormones are synthesized in the brain as well as in the gonads, and that synthesis is independent of gonadal synthesis. And so we don't only need to look at the role of these steroids in circulation and affecting the brain indirectly, but we also need to look at the effects of these steroids directly in the brain, and that may be influencing a lot of behavior as well as circuitry and also perhaps neurodevelopment.
Right, so just to reiterate, the point that was brought up was about neurosteroid production, and that is something that was hit upon a little bit in some of the talks, but definitely is a factor to consider, that steroids, which are both produced and metabolized directly within the brain. Nora, did you have a comment?
Yeah, no, great talk. And my question was, it just actually reminded me of a paper, I think it was published like 1 year or 2 years ago, on biological psychiatry, if my brain remembers correctly, in which they were doing a kappa opioid receptor imaging study, and they showed significant differences between males and females. And if I recall correctly, females have significantly lower levels of kappa receptors. So in the animal literature, have they been able to actually show those differences? And what impressed me of that paper was that the effect sizes are actually quite large. Do you want to comment on that?
Sure, yeah, there have been a number of studies looking at both dynorphin levels, kappa receptor levels, kappa receptor binding, GTP gamma S, and there are brain region specific sex differences in the animals that don't always match with human. And yes, it's very exciting that that's the case in humans and gives more, I think, more rationale for when studying things like kappa receptor antagonists as potential treatments, that females may be less responsive to kappa antagonists if they have lower kappa receptors to begin with. So I don't know if I answered your question. Yes, the work's been done in animals, but it's very brain region specific.
But I mean, what was intriguing about the humans is that you see it all over the place. I mean, that's what gets caught in my brain, because it's not so frequent that we see these differences between the genders so clear cut, and it was not just region specific.
Yeah, I think, rats in particular have very low basal kappa receptor levels, so any work that's been done has been a heroic effort. Mice have a little bit more, but it's not like you're describing, it's up some places, down in other places.
The aspect about it that was also intriguing when you're dealing with PET imaging is that, I mean, a confound in any of these studies is that to what extent it reflects levels as opposed to competition with dynorphin. And even though it's not clear-cut, the sensitivity of that particular ligand, I think it was one of the LY compounds, there is some data to suggest that it may be sensitive to dynorphin. But again, that is always a confound with these PET studies.
Well, Nora, could you comment on then taking that one step further and how that might reflect back on anything in terms of the opioid use crisis and gender differences in treatment?
Well,
or
you know how our brain tricks you, because it's actually overall, if you look at the trajectories and the epidemic, I mean, we have a significant differences in the heroin and the synthetic opioids between males and females. So males are significantly higher than females. Where we don't see the difference is from prescription opioids, and that relates to a certain extent to the fact that women are more likely to be prescribed opioid medications for pain. And you see that those differences also as a function of age. So yes, you see the epidemic affecting distinctly males and females, but highlighting the point that many of those factors may be socially driven. Yeah. And I predict that, because what it's saying is if there are as many females as males, when they are given the chance to be given prescription opioids, that means that the sensitivity pharmacologically may be similar, whereas being engaged in environments or communities where you're more likely to be exposed to opioids or synthetic opioids may be at higher risk for males than females, as we've seen for other drugs. But what my brain was tricking me into believing is because women have a higher vulnerability of depression, and we do see that a component that is very, very significant, and George Koop has been speaking about it many years, is the negative side of addiction and the dysphoria component that you see very, very strongly in people that are addicted to opioids. And in fact, one of the things that patients that are addicted to opioids say when we ask them, what do you need from us in terms of treatment, they complain of depression, and that leads them to actually relapse. So in my brain, the trick was, could it be that females have more dynorphin and therefore they are more sensitive to the dysphorigenic effects of opioids and therefore more liable to depression? But this is my total prejudice, because I mean, you are just seeing a decrease in the expression of the receptors. I do not know what it is or not. But in the animal studies, if this is correct, I mean, I think there should be a means to try to look at it, certainly in non-human primates, perhaps. That may be a closer model.
Yeah, I mean, certainly also to answer that question, Nora, is once you start getting into the anhedonia, in addition to the addiction issues, you have all other circuitry right, so it becomes very complicated for gender differences outside of just the opioid.
Absolutely, and then you add on top of that, when you're speaking about the prescription opioid crisis, that pain itself, and there's some data from the group at St. Louis University, suggests in animal models that you are enhancing the release of dynorphin and with chronic pain. Then, of course, that makes you more vulnerable for dysphoria.
Mm-hmm. Thank you, Nora.
Yeah, thank you.
One last question.
Yeah, the last question is this. We work with non-human primates, and most of the work that's being presented is in mice and rats, but we have rhesus macaques and marmosets. And in our work in marmosets, in the marmoset, the greatest density of the oxytocin receptors in the accumbens. And so I wondered, I don't know about mice and rats, but since we're talking about sex differences, I wondered about oxytocin and its role potentially in interacting in these regions.
So I don't know much about oxytocin and the accumbens, but what it made me think of is some work by Brendan Aragona looking at dynorphin expression in the prairie vole and social behavior. So sort of the flip side of oxytocin, with the idea that dynorphin in the nucleus accumbens decreases social behavior, has the kind of anti-oxytocin effect. And there are definite sex differences in those studies. So it's not quite the answer to your question, but.
All right.